Okay, so here's class 19. What I want to do in class 19 is I want to cover this healthcare reform book. There's one quick article I want to hit before that you'll see, but I want to do this healthcare reform book. There's a lot in this book. I won't cover everything in it. I'm going to hit some highlights. I encourage you to at least read the highlights. It's fairly lengthy. It's 30 pages of notes on a book that's probably several hundred pages. So there's a lot more in it than what I have in the summary, and in the summary you just have the highlights. You can certainly read more than just the highlights if you'd like, if you got some time. It's a very fascinating book. But before we do that, I want to try something else. I want to show you another article. So this is an article that I got from the New York Times just a couple of days ago. We talked about this earlier about surprise bills, and one thing, remember when you do this paper, you have the overview, then you have the statement of the problems, and there's a long list of problems, statement of solutions. Here's a good chance for you to think about a solution for one of the particular problems. We talked about a problem of lack of transparency for billing, and under that we talked a lot about surprise bills. So here's a great article that talks about the surprise bills, and then you might think, what is the solution? Congress is talking about bills to pass. You might even look up and see what their bills actually say. But you know, this article talks specifically about transport, whether it's air transport or ground transport. That tends to be a huge surprise bill. So here's a lady who was flown by a helicopter to a hospital, and they charged her $52,000 for the trip. And then it talks about Congress was trying to prevent surprise bills because they couldn't pass it, that it's really especially hitting coronavirus patients. So again, surprise charges, they come from out-of-network doctors, from ambulances, medical laboratories, and a lot of times the patient that's paying these huge surprise bills, they didn't even pick the care they provided. We'll show you the example of this lady that was flown from her house. She had no choice in the matter. So how would you actually construct a bill? Would you do something that says if a bill is over a certain amount and there's a probability that the insurance will not cover it, that the patient must sign for their responsibility for that? What if the patient's unconscious? What's the rules then? Think about it. Someone is unconscious and you have the right to use whatever service it takes to save their life, no matter what it's going to cost them. What are you going to do? Well, you're going to find the thing that makes you the most money. And you talk about ambulance services, especially air services. You don't have any choice in that. There's usually one provider. One of my graduate students actually works on these type of programs, on deciding who's going to provide the emergency care in this city. And it's a contract between the city and that provider. Do they think about insurance coverage and what insurance is covers in this area? Does it cover these costs? So if someone's unconscious and an ambulance has been called, and after the fact they're going to get a $52,000 bill, how would you protect that? You don't want to get in the point where ambulances can't get reimbursed because there's some law that says unless you get pre-approval, and so ambulances stop showing up and people are dying. So how exactly would you construct it? So you might actually look and see what it is that Congress is trying to do. So the plan to ban these kinds of bills was popular, had bipartisan support. The White House supported it, but it fell apart when a private equity firm, which many of these medical providers that deliver surprise bills, they own many of these. That particular private equity poured millions into advertising opposing the plan. And we talked earlier about how, and we'll talk in this book here, how much Congress is in the pockets of the healthcare system. So here's the lady. She's flown from her house to a hospital. Her health plan initially said it would pay $7,500 of that $50-something thousand bill. But then it rescinded and said, we're not going to pay that. So the patient, she was housebound because of coronavirus symptoms, was left to pay that full $52,112. She was intubated and on a ventilator when her providers felt it was necessary that she be transferred. So someone's making a decision, she needs to be transferred. She had no decision in the selection process. Someone else is deciding, yeah, let's do this. It's going to cost her $52,000, but hey, it's to save her life. How do you fix that problem? And it's a tough one, because obviously you don't want these providers saying, well, it's going to cost a lot of money, maybe we shouldn't do it if her life depends on it. So it's an interesting article. Congress set up a $175 billion provider relief fund to help hospitals in their battle against the coronavirus. One condition of accepting these fees was that these funds was that they not have surprise bills. But a lot of times the surprise bill, that part of the legislation had significant gaps. One gap in particular is ambulance services. So air ambulance bills are often the most costly type of surprise bill. The median charge is $38,000. And so the patient's probably going to have to pay, $21,000 of that after the insurance. The prices are rising fast, 15%. Numerous states have enacted laws to restrict surprise bills, so the states are getting into it, not just Congress. However, there's a law, the 1978 Airline Deregulation Act, which says air ambulances cannot be subjected to state rate setting. Even though it's directly related to healthcare, the law specifically says states can't regulate that, and obviously Congress can. Here's a lady, she called for an ambulance for her husband. When they got there, they said, you know what, you're pretty sick, you're pretty weak yourself, ma'am. So they had a second ambulance take her. So she gets two bills for $1,500 each. And she lived right around the corner from the hospital. She says, I could have walked to the hospital and saved myself $1,400. Now, her insurance did cover it, so she ended up only having to pay $294. But still, $294 for someone to drive you around the block is pretty excessive. So think about this issue. We talked about it before, but what is your solution? And I'd be really excited if some of y'all actually looked and see what exactly is the language of the bill that's going before Congress in order to restrict these surprise bills. So now what I want to cover is this book. I really love this book. I encourage you to get it. I think you'd find it incredibly interesting. It's a little bit shocking all the way throughout. It's extremely well researched. The bibliography on this thing goes on for 100 pages or more. A lot of detail. In fact, I found myself interested in the bibliography because they reference these stories that are just amazing stories, and you want to go back and actually read longer articles about some of these events because they really are pretty amazing. I'm not going to cover everything that I've highlighted. I'm definitely not going to cover everything, and I'm not even going to cover everything I have highlighted. There's some things I have highlighted in green, and I want to cover those, and there's some in blue that I think are really important. So the stuff highlighted in yellow I'm not going to cover. But the key of this book, and this is what I want you to really get out of it, is we talk about Medicare and Medicaid and the Veterans Administration, but this is really focused on Medicare, although they do talk Medicaid in here some. But the concept of fraud and waste and how much that impacts our healthcare system. And when you read this, if you're going to argue for Medicare for all, this is the book you've really got to grapple with, because this book makes an argument that Medicare is very poorly managed, and they'll give you some arguments on why it's poorly managed, that it's not necessarily the incompetence of the people managing it. It really comes down to the volume that they have to manage, that it's practically unmanageable because the volumes are so enormous. It essentially has to pay whatever comes. Whatever bills come, they have to pay them. So their argument is, let's get to the root cause for our high cost, why healthcare costs so much in the United States. And they argue that there's two main causes: the intrusion of the political process and over-reliance on insurance. That should sound familiar. We've seen that as is a problem. In fact, the very second article, first two articles we did, we call it insurance, and that's not healthy. And then the second one, how the healthcare system killed my father. Those two both talked about, especially the over-reliance on insurance. The incentives that result from these fundamental errors render healthcare transactions financially opaque. So we just saw that with surprise bills. These incentives enable and encourage healthcare providers for whom opacity is a boon. So lack of transparency helps them tremendously to mistreat patients and overcharge consumers and taxpayers. So the system is set up to fail. They do mention the Singapore model. That might be something you want to do some research on. They're arguing the Singapore model was a very good model. They talked of 5 big problems with this process. You can see the political process and third-party payment are the first two. They talk about the others are directly related to it. High prices, poor quality care, opaque prices. Those 3 things are the result of the first 2. And in 4 lessons, they're not bad people. We can rescue ourselves by how? By changing healthcare from an insurance-based, employee-based system to one where we mainly pay for it out of pocket. That gets back to that, really the first 2 articles again. Higher deductibles, medical savings account, health savings accounts. The first article was talking about $3,000 to $5,000 deductibles. The second article is talking about $50,000 deductibles. But convert healthcare like any other good or service that is consumer driven. You have too many monopolies. So, how do we break up the monopolies? So insurance, this is back to the very first article. Insurance could cover the expensive stuff. Patients should pay for all the routine stuff. Here's one source reports that if all anti-poverty programs, this is to me is just an amazing thing. All anti-poverty programs were replaced with simple cash transfers at the current spending levels, poor families of 4 would receive an annual income of $70,000. And I find that interesting. You look at Medicaid for the poor, and Medicare for the poor as well, but more for senior citizens. We're spending a lot of money on the poor. Do you think they feel like they're getting $70,000 in services? So some of you might have been big fans of the universal basic income. I forget the name of the politician that was running under that platform. It's not like a really smart guy, I just can't remember his name. And he was pushing that. And universal basic income, if you eliminated everything else, no food stamps, no Medicare, no housing supplements, no education, no public education, you eliminated all of that and just gave poor families a check for $70,000. Most economists would say, yeah, that's probably, they'll make better decisions with that money. But this gets back to that second article. We're spending so much money on this. What benefit are we getting other than we're incentivizing the system to be expensive? So pretty amazing number, very round number, so I'm sure it's, plus or minus whatever. He talks a lot about the pharmaceuticals, and you'll see that in here and some of the really bad incentives for pharmaceuticals. Here's an example. Gilead argues that at $85,000, this drug is still a good deal because by curing hepatitis C, it reduces the number of liver transplants and other expensive medical treatments infected people will need. That's not how markets work. You don't get to charge a price based on where it saves other places. You charge a price based on the supply and demand of a competitive environment. So no product gets to say, hey, because our product's here, look at all the wonderful stuff we're doing, so we're going to charge a fortune. No, it comes down to what are your costs, what's your cost of capital, and what's the competition. In a competitive market, prices are based on what it costs to make them, not based on the benefits that yields. That's a wonderful thing about competition in free markets, is we as consumers are able to spend a little bit of money to get a huge benefit because what we're getting is not that expensive to create, and there's a lot of competition, and so that drives costs down and drives prices down, even though the benefit to us is huge. So Competition drives prices down, and consumers enjoy the surplus between the actual price and the highest price they'd be willing to pay. So, for me, for air conditioning, I probably spend about 40, 50 bucks a month to get air conditioning. How much would I be willing to pay for that? Man, I'd be willing to pay a fortune. I'd be willing to pay $1,000 or more a month for air conditioning. But because of competition, I don't have to, because it doesn't cost them $1,000 a month to produce the electricity to give me an air conditioning. So no, that's not the way markets work. About half of the most transformative drugs invented in the past 25 years had their origins in research that we paid for with our tax dollars. So we kind of already own these drugs anyway. Research shows that a medication's price has no relation to how well it works. So we've got some problems. This book really beats up on the pharmaceutical industry. $1 million contribution from pharmaceutical company to a copay charity can keep hundreds of patients from abandoning a newly priced drug. Now think about this. This is pretty incredible. You donate money to a charity that gives people money so they can buy your product. Boy, that's really wonderful. So you donate $1 million to a charity, and they're going to take that $1 million and give it to their clients that will then give the $1 million back to the pharmaceutical company. And the pharmaceuticals, really tout this. Look what wonderful people we are. We're helping poor people buy our drug by donating $1 million to them so they can give the $1 million back to us. It's a pretty interesting process. Here's another example of pharmaceuticals. So here's a drug that sold for $2,300 a dose, 38 times more than another pharmaceutical. 6 randomized clinic trials found that the two drugs are largely equivalent. Why do so many eye doctors use the pricier drug? Medicare pays physicians a lot more for using the more expensive drug. So if you're wondering why Medicare does not simply pay the same amount for the two drugs or require physicians to use the cheaper drug, the answer is the law prevents Medicare from doing that. Pretty amazing. Why is that? Because there's so much money going into Congress from the pharmaceutical industry. This creates a large incentive for cardiologists to implant stents even when they are not necessary. According to a news article, 2 out of 3 elective stents or more than 200,000 procedures a year are unnecessary. This gets back to what we talked about, overdiagnosis. Stents is an example of this. After reading some of the books on stents, I've come to the conclusion if I have a doctor recommends a stent for me, I think I will go get a second, third, and fourth opinion. Just seeing that stents can actually cause more harm than good. The patients who received the stents weren't any less likely to die or suffer non-fatal heart attacks, unplanned issues, compared to those who only took medication. The financial costs of implementing stents and the hundreds of thousands of patients who do not need them reportedly runs about $2.4 billion a year. That seems small versus the trillions, but it's one example of a cost that is completely unnecessary. That's just for the stents. To calculate the total cost, you have to add in the millions upon millions of dollars spent on blood thinners and medical monitoring. So there's a good example of overdiagnosis, and again, driven by incentives. 2 doctors performed unnecessary but highly profitable cardiac procedures on over 750 patients. The surgeries were thought to have killed 94 patients and to have caused many others to suffer strokes, paralysis, and heart disease. So not only is overdiagnosis costing a lot of money, it's also killing people. People are getting treatments, very invasive treatments they do not need because the doctors get reimbursed at a high rate. The researchers hypothesized that mortality would be, this is an interesting one here. This is a group of doctors who were at a conference. And so, it's hard to find control groups. So you're trying to understand the value of a particular medical procedure. And here you have a week where a large number of the surgeons were at a conference, at a convention. And so the researchers say, well, let's look at mortality rates during the convention versus normal mortality rates. Because obviously if all the doctors are at a convention, mortality rates should go up because you have less qualified doctors doing the surgeries. You have fewer surgeries going on, so people are, waiting and dying while they're waiting. So let's see. So they hypothesized that mortality would be higher during the meeting dates, and the differences in outcomes would be largest in teaching hospitals, where a disproportionately larger fraction of cardiologists may attend the meetings. To their surprise, patients suffering from heart failure or cardiac arrest who showed up at a major teaching hospitals while the conventions were underway fared better than those who arrived on other dates. High-risk patients fared better when doctors at teaching hospitals were off at meetings because they received less care. The video I want y'all to watch, then this one doctor says, "I'm paid more when I harm my patients." It's an amazing thing, goes under the quality, quality and inconsistency of care. Pretty amazing finding. Here's another pharmaceutical example, but here we're looking at how a particular provider took advantage of the system. So this particular drug comes in 100 milligram vials, and the acceptance treatment protocol was to give a dialysis patient an entire vial once or twice a month. This produced zero waste. This company didn't do that. Instead, the clinics gave 25 milligram doses more frequently. Instead of once or twice a month, they went 4 to 8 times a month. But because the drug only came in 100 milligram vials, each 25 dose produced 25 milligrams of waste, which they threw out. And then they billed Medicare for the full 100 mg vial plus 6%. The more medicine they wasted, the more money they made. And so people complained. Medicare changed the rule. You think, well, that fixes it. So what happened? They contended that they stopped wasting drugs when Medicare changed the payment approaches in 2011. Under the new rules, Medicare paid dialysis clinics a flat rate of $230 per treatment. According to whistleblowers, DaVita quickly switched its regimen from 425 injections to 100 injection because in this case, the waste was hurting them. They were buying the drug, and if they wasted the 75, that went out of their pockets because Medicare is paying them $230 no matter what they do. So you can see, again, it gets back to incentives. The incentives are absolutely driving the wrong type of behavior. A big problem with the American healthcare system is that it pays providers well for doing things that don't actually help patients. Another great quote you could use in your paper. Sorry I didn't number the pages here, but I do have the pages of the book here. So if you're trying to find these, they do go in order. So that comes from pages 120 to 121. So that's a great quote. Back surgery to relieve pain are, in the majority of cases, no better than non-surgical treatment. We talked about this earlier in the class. Yet doctors perform 600,000 of these surgeries each year at a cost over $20 billion. We saw a $2.4 billion waste earlier. Now we see $20 billion waste. Despite studies showing that the surgery to correct these problems of the knee is no better than sham surgery and is much more expensive and invasive than physical therapy, doctors perform these the procedure on more than 500,000 Americans a year. There's another $3 billion. What about prostate cancer? We'll definitely see that when you watch the video. Lots of men die with prostate cancer. Relatively few die of prostate cancer. PSA is the test you do, the screen for prostate cancer. This screening results in small or no reduction in prostate cancer specific mortality and is associated with harms related to subsequent evaluation and treatments, some of which may be unnecessary. A review of 10 trials involved more than, here we are on the mammography trial involving 600,000 women, so there was no evidence suggesting an effective mammography screening on overall mortality. The problem is that the early, less reliable studies spawned whole industries because doctors rush to perform services and prescribe medications that they expect to help patients. Years later, when better research reverses that, you can't shut down a whole industry because everybody's dependent on that for their livelihood. So the original study says, yeah, women should get these tests in their 40s. Later studies said there's no impact on mortality. We're actually not helping women by having to do that. We're causing a lot of stress, and sometimes we're actually giving them unnecessary procedures. But the industry was completely built up. And once you have that, it's really hard to kill it. Only a fraction of what physicians do is based on solid evidence from grade A randomized controlled trials. The rest is based instead on weak or no evidence and on subjective judgment. You know, evidence-based medicine, I think, is a huge part of the problem. I do know doctors, that's real important to them, and they want to see those trials. I've got a graduate student right now who is a PhD medical doctor who's also a researcher, really strong in statistics, has taken a lot of statistics class. He loves that kind of stuff, but there's a lot of practices out there that are just based on, well, this other doctor does it, so it must be right, so I'll start doing it and make some money off of it. You can see this study of controlled trials. There's 11% is beneficial. Another 24 is likely to be beneficial. The next 7% is it's beneficial, but it causes some harm, so there's a trade-off. The next 5% is it's unlikely to be beneficial. It might be. The next 3% is likely to be harmful. And then 50% we just don't know. We're treating people, half of our treatments, we're treating people with treatments we're not even sure even work. I'm sorry I don't have a better graph here. If you want to put this in your paper, it'd be pretty impressive. You could probably create this graph yourself. It's pretty easy to put it in Excel. You can create it and make it look prettier. This organization was overwhelmed when it recommended that healthy women in their 40s should not have routine mammograms. The guideline reflected their assessment of the evidence that for normal women in this age group, the expected health benefits are so small and the expected health costs are so large that the procedure would probably do more harm than good. The balance tilted negative because they generated a lot of false positives, which caused women to undergo unnecessary treatments for tumors that pose no risk to their health. So how did doctors react to that? Trauma doctors piled on. Time magazine quoted Dr. Dearshaw, the director of breast imaging at this particular center, as saying that he was appalled and horrified. There is no doubt that mammography screening in women in their 40s saves lives. He says there's no doubt. There's just a study that says not only is there no doubt, we're actually quite confident that it doesn't save lives. To recommend women abandon that is absolutely horrifying to me. Now, is he speaking from research or is he speaking from his own benefit from doing these type of treatments? So, you know, what are the incentives here? Here's another pharma study. Here has to do with campaign donations. Between 1997 and 2015, pharma donated $3.3 billion to congressional campaigns, 43% more than the second largest contributing industry. Hospitals, nursing homes contributed $1.4 billion. Physicians and others contributed $1.2 billion. And in essence, they contributed over $700,000 per legislator per year. Now do you see why legislators do not want to go against this industry? You can't get reelected. That's a big part of your campaigns. Like, although I know now in presidential campaign, you know, we're talking $50 million for a campaign or more than that. Probably billions of dollars now in campaigns. So they're getting expensive. But for a local congressperson, $700,000, that's a big part of their campaign contributions. Now, what I think is really interesting to me is when Congress plays a game here. So Congress had this bill. They were gonna fix this particular part of the healthcare system, but it was going to cost the physicians a lot of money. And so what Congress did is they passed the law, but then they delayed it a year. And because they delayed it a year, the next year they got a lot of contributions, campaign contributions, to try to get Congress to delay it another year. And Congress is like, wow, this is pretty cool. We'll just keep delaying this bill 1 year every year, and we'll get all these wonderful campaign contributions. So it generated substantial campaign contributions. Physicians needed a new fix every year. They had to bribe Congress to get it. Congress and the lobbyists had an interest in making the repeal process as profitable for them as possible, which they did by forcing the medical profession to live through a series of 1-year bills. I mean, everybody's winning except for the U.S. taxpayer and the U.S. consumer. Unnecessary medical care costs account for 30% is what's spent on healthcare. You can find some studies that say it's higher than that. With total spending now north at $3 trillion, this means Americans waste $1 trillion on healthcare in just 1 year. That's $400 billion more than they spend on our national defense. We could reduce medical spending by 50% without doing damage to our health. Health policy experts know that we see at best only weak aggregate relations between health and medicine, in contrast to apparently strong aggregate relations between health and many other factors such as exercise, diet, sleep, smoking, pollution, climate, and social status. Cutting half of medical spending would seem to cost little in health, and yet would free up vast resources for other health and utility gains. Back to that second article, remember that he talked about that, I forget what he said, 1.7 million we spend over our lives on healthcare, and a lot of it, there's no evidence that it's actually improving our health. Almost 100 seniors a day die from medical procedures they did not need and should not have received. Here's another example. Here's a doctor who told healthy patients that they had cancer so that he can make money giving them chemotherapy they did not need. He reportedly gave one of his patients 155 chemo treatments over 2.5 years, even though the patient was cancer-free. When you have bad incentives, you get some bad players. So, this article started off saying it's not that doctors and hospitals are evil, it's that the system has bad incentives. But when you have bad incentives, evil people will come into the system. 2 plastic surgeons charged more than $250,000 to sew up her incision, a task done by a resident during her previous operation. There's that surprise bill we were talking about just earlier. A few exceptional hospitals do require all doctors to belong to the same insurance networks that they do, showing that hospitals can solve this surprise bill problem if they wanted to. Hospitals see no advantage in protecting patients from surprise bills, even though the bills worry patients greatly and saddle many of them with significant costs. Surprise bills are a consequence of a lack of market competition. So again, think about it. What other industry, I've mentioned this before, what other industry would do that? If I was watching an Australian documentary on some prize bills related to plumbers and those kind of things, but boy, that was, even in that case, the guy was being ripped off by tenfold. He was getting charged $200,000 for something that should have cost him $20,000, but he still had to initial the $200,000. He had to say, "I accept the $200,000." So even then, this guy's being, he's on the news for ripping his customers off, but even he lets the customer know what he's going to charge in advance. So as evil as he was, far better than what we have in the healthcare system. Medicare and Medicaid receive something like 3 billion claims per year. Here's what I'm talking about. Why is Medicare so defrauded, so wasteful, and so seemingly incompetent in what they do? And I'm sure they have very respectful, honorable people working there, but look at what they're dealing with. 3 billion claims per year for a human being to spend 5 minutes reviewing. So just 5 minutes per claim, you would need 125,000 people working 2,000 hours. There's just no way we can afford to do that, and yet we know we're wasting a lot of money. Healthcare providers that harm patients can make more money doing so. They get paid once for delivering service that injure patients and a second time for treating the injury they inflict. This may explain why healthcare providers harm patients so often. There's another good quote from page 245, very similar to what you'll see in the video I want you to watch. Research has found that patients at the worst American hospitals were 3 times more likely to die and 13 times more likely to have medical complications than if they visited one of the best hospitals. Here's a great quote, page 252. I don't know what page, it's page 20, I guess, of this document. We talked about inconsistency of quality, city to city, hospital to hospital. That's a great quote there. It seems likely the few hospitals know where they stand, that they simply can't make money measuring or improving quality. What other industry can you say that about? Our politically controlled third-party payer system has taken away any business case for improving quality. There's a great quote you could put on that inconsistency for quality. You would think, wow, one hospital costs 13 times more complications than another one. you would think that hospital will go out of business and the one that's number one would be in first place. But without that data and without, most consumers don't shop hospitals. They go wherever their doctor sent them. And most consumers aren't even that good at shopping doctors, how to find the right doctors. So they're very much beholden to whatever the doctor tells them. So no one asks those quality questions. But in the healthcare sector, the connection between price and quality is far weaker. Indeed, it can be inverted with better providers charging less than inferior ones, but patients don't know this. So patients will use price as a signal of quality, even though there's no relationship there whatsoever. It reminds me a lot of the financial services industry. Tim Duncan sued his financial advisor. Tim Duncan assumed, well, this guy's charging him a lot of money. He must be really good, and he found out it was just the opposite. The guy he used was really bad. I wish Tim Duncan had come to me. I would have managed his money for free. But it seems rational. You hire the most expensive because you're rich and you're going to get the best service. And in medicine and in financial services, that may not be true. Medicaid coverage increased annual medical spending by $1,200 per household. In other words, the winners use about 35% more medical services than the losers. Having Medicaid coverage made only a modest difference in the winner's health, however. So here they're comparing the people who spend more because they have Medicaid, they have Medicare, they have Medicaid, they spend more. Does that mean they're healthier? Having Medicaid coverage made only a modest difference in the winner's health. However, although it did reduce financial strain, the winners use emergency rooms 40% more often, including increases in visits for conditions that may be most readily treatable by primary care. When people are insured, they use all types of medical services more often. Hospitalizations, visits to doctors, use of prescription meds, all spiked. Why? Right at age 65, because that's when they're eligible for Medicare. It is hard to come up with better evidence that the demand for medical treatments is in fact quite elastic. Now, I always quote Milton Friedman. I saw him at a conference where he said, healthcare is the most inelastic product there is. So he might debate this, but it may be inelastic because if you're dying, you're willing to spend whatever. However, if you're not dying, you need a treatment, and you don't have insurance, and one treatment costs you $5,000, and another treatment that's just as good costs $500. What they're saying here is, yeah, consumers will actually shop. When it comes out of their pocket, they will actually shop around, and the pricing is actually quite elastic. So if you know something's cheaper and it's better, you will definitely shop around. You will pay for it, unless your insurance is covering you. Then you don't care. People spend more on health because they are insured, and buy more insurance because of the high cost of health care. I mean, it's a circular thing, which is just spiraling out of control. And so here you go, all you young people, you're in college, you're wanting to save up money for your retirement, but just realize you are subsidizing the wealthiest generation in U.S. history, and it's today's senior citizens. They're the wealthiest group of people that have ever existed on planet Earth as a group. They're far wealthier than your age group. And what are we doing for them? We're subsidizing them from your age group. Just look at this. A typical one-earner couple can expect to receive Medicare benefits worth $427,000, only paying $70,000 into the system. A 200-person couple, they get $427,000 benefits and they pay $102,000 in taxes. Part B premiums now only cover 25% of spending on physician services. 75% of Part B spending is an untaxed gift. So your generation, we can't maintain this. Your generation is one that's going to have to pay the piper. And yet the older generation, boy, I just saw someone, a senior citizen the other day saying senior citizens shouldn't have to pay property taxes and because they're old. And think, well, if they're old but wealthy, why shouldn't they pay property taxes? But that's the argument. Old people should get subsidized, even though they're wealthy people. And, that's, to me, if they're wealthy, they shouldn't get subsidized. They're poor, we should take care of them. But that's not the system that we have. The system subsidizes even the wealthiest people. Proponents of Medicare for All treat the paltry amount that Medicare spends on administration as evidence of superior efficiency when it actually reflects government's staggering profligacy with taxpayers' money. In 2005, Medicare's administration costs for $509 per primary beneficiary compared to private sector of $453. So when you add all the costs in there, it's actually more expensive. Just ask why Medicare doesn't bargain over prices already. The program spends more than $630 billion a year. So its financial clout with doctors, hospitals, and drug companies is enormous. But throughout the entire existence, Medicare has been a price taker. It has never bargained over prices. That's one thing that's fairly unique in the United States. Most other countries, especially you think about the UK, they definitely bargain for prices. They say exactly what they're going to pay. But Medicare doesn't. Why? Because if you have congressmen, congresswomen receiving $700,000 a year in donations from these healthcare providers, yeah, they don't want to do this. If they vote for these type of bills, they won't get that money the next year. So there's bad incentives. In fact, Congress even forbids them from negotiating. So when Congress makes really bad laws, then look at the lobbyists and where the money's coming from, and you can figure out the purpose and the source of the bad laws. History provides no basis for believing that the government will ever improve quality, reduce spending, or get fraud, waste, or abuse under control. Yet Medicare for All proponents persist in thinking that the government will magically run an enormous single-payer program better than it ever has run any other healthcare program before. The U.S. government appears to be unusually subject to pressure from special interests and uniquely incapable of rationing. I hear some people say we need a single-payer program, and my argument is we already have one. The largest single-payer health insurance program in the world is in the United States. It's called Medicare and Medicaid. It pays for over 70% of the healthcare costs in the United States, and it is absolutely bankrupt. More bankrupt than any other system. And every other country is struggling with this, but the U.S. is just absolutely bankrupt. Most other countries have bigger problems than the U.S. because they have larger baby boomer population, but they don't have the spiraling out of control costs that the U.S. has. From 1996 to 2005, the real price of service fell by nearly 30%. Here we have the LASIK example. So remember, one of the problems we listed is that for some reason technology in healthcare tends to drive up cost. Is that because it's unique to healthcare? And this paragraph's arguing, no, it's not unique to healthcare, it's unique to insurance. When the healthcare is first-party payment, the person getting the care is paying for it, costs actually fall. So the real cost of LASIK has fallen 30%. So that's an inflation, even adjusting for inflation, with inflation adjusted out, it's 30%. Why did LASIK and cosmetic procedures become more affordable? Consumer demand, first-party payment, competition. Over the same period that LASIK and cosmetic surgery became cheaper, the prices of medical services covered by insurance rose 2 to 3 times the rate of inflation. The medical profession contends that retail clinics endanger patients. So see how the profession does not want competition, especially cheap competition, even though the arguments against these cheaper approaches and procedures is very, very weak. They still argue it, and it's scary, right? They say, hey, you can't do that. You don't have a medical degree. It's too dangerous. You're seeing these things crop up in Costco's and other places, even CVS's and Walgreens. But they contend that retail clinics endanger patients by using simplistic decision and treatment protocols, disrupting doctor-patient relationships, overprescribing medications, and fragmenting the delivery of healthcare. These assertions have little or no empirical support. In fact, when it comes to treating minor illnesses, retail clinics often achieve better quality scores than physicians. The conclusion was clear and unambiguous. Retail clinics provide less costly treatment than physician offices or urgent care centers with no apparent adverse effect on quality of care or delivery of preventative care. How much less costly? 80% less. So one of the solutions I have listed is alternative approaches. You'll see that, whether it's medical tourism or these retail clinics. So here's a good quote that you could bring into that section to show that the industry's fighting it because obviously it's a disruptive innovation, and yet the data supports that this is actually good for consumers. A hysterectomy is likely to cost 32. Here's again examples of differences in costs This goes in that first part of the paper of the problem, a good quote on 341. A hysterectomy is likely to cost $32,000 in the United States, but $4,000 in Thailand. A kidney transport, transplant, $150,000 at home in the U.S., $25,000 in the Philippines. An American couple can expect to spend about $20,000 for a round of vitro fertilization here, but in Israel, only $3,500. They offer services that are as good or better than what you can get at home. I mean, Thailand, I would love to visit Thailand, man. They got some beautiful mountains and beaches. I know they're politically just having a political issue right now, but still, if I can save $28,000, I'll spend $5,000 on travel. Maybe I don't want to do much vacationing after a hysterectomy, but who knows? You have plenty of money, you can recover and then go enjoy the beautiful beaches. The world-famous Cleveland Clinic reportedly charges more than $100,000 for this treatment. You can get it $1,600 here. In India, we talked about this guy. Big difference for the same quality. Their mortality rates are comparable with others, are better. They boast a 1.27% mortality rate and a 1% infection rate. That compares to 1.2, just slightly worse, and 1% exactly the same. The case study was comparing their mortality and infection rates not with the average U.S. hospital, but with the best U.S. hospitals. And they were almost exactly the same, just slightly worse on mortality. The New York Times reports that this smart shopper, we talked about this earlier, gives workers a list of providers in the network and rates them based on quality. It then provides cash incentives to use the lower cost providers. So first they convince you that the quality is the same or even better and it's cheaper, and hey, we'll pay you $50 if you go there. Wanted to gain their business, the local providers who know that employees share this discount, they actually will come out and start advertising their prices and fees. So you get competition. It is amazing. You put competition in the system, you give people information on prices, you give them information on quality, and overnight the system is fixed. It is truly amazing. And yet the system is fighting both of those things. Currently, the U.S. accounts for over 40% of the pharma company's total revenue, even though it only contains 5% of the world population. We essentially, Americans, are subsidizing drugs for the rest of the world. The healthcare sector loses about $1 trillion a year to fraud, waste, and abuse. There's that fraud. You could put that as a quote in that section. But it's important to see that this game occurs only in the part of the healthcare system where third-party payers, where insurance predominate. There are no comparable stories of fraud, game playing, predation in the retail sector where people buy things directly. It's only when someone else is paying. Boy, that's a great quote. You could bring that quote into the very, very beginning. We bring that first article where insurance should pay for high severity, low frequency things. This is a great quote that just shows insurance is the wrong model. Obamacare, the Affordable Care Act, prohibits insurance from charging sick people more, for denying coverage on the basis of pre-existing conditions, and for charging older people more than 3 times as much of people who are younger. The actual ratio should be 6-to-1. Again, you're subsidizing wealthy elderly people like me. You're going to be subsidizing me here pretty soon. So I appreciate it. I really appreciate you. You're paying twice as much as you should, so that I can pay half as much as I should. Those who support the Affordable Care Act are using the insurance system to transfer resources from low risk to high risk groups. So yeah, I always call it Affordable Care Act. I know President Obama pushed it. It was his baby, but Congress is the one that did all the details. And I know there's things in that bill that President Obama did not like. You read, there's a great book I read. One of his advisors, he was actually pretty disappointed that the Affordable Care Act did not address the cost side better. So that's the reason I keep it. I think it's all of Congress and all of, a lot of this is Congress's fault. Some of the compromises they made because they get so much money from the industry. You think back to the Clintons, and when they tried to do this, the industry ran out with these extremely effective commercials and destroyed the entire thing. And essentially Congress said, you know what? They donate a lot of money to us, and if we don't have them on board, they're going to go out and kill this bill. They're going to scare the American voter, and they'll be, so let's fix it so that they're not harmed. And so, yeah, you're seeing in here There's always winners, there's always losers, and here the losers are young people. Rates for people ages 18 to 24 increased by 45% above what they should pay, so that those ages 60 to 64 could be reduced 13%. How is mandating a price break on health insurance for this higher income group at the expense of a lower income group fair? This guy, he got really famous for saying this. You may have seen him in the news back, well, if you were paying attention back then, you might have been in middle school or elementary school back then, but a health economist who helped design Obamacare acknowledged that transparency about forced wealth transfers would have doomed the Affordable Care Act. Lack of transparency is a huge political advantage, and basically call it the stupidity American voter or whatever, but basically that was really, really critical for getting this thing to pass. Yeah, he got in a lot of trouble for saying this. But yeah, if you've got to get the senior citizens on board, how do you get the senior citizens on board? You force young people to subsidize them. It funnels resources from less well-off to the more well-off. That's why the Affordable Care Act had an individual mandate coupled with a tax penalty. So what is President Obama was saying? Now it's interesting, when he was running for office, he was absolutely against the individual mandate, but I think he discovered you have to get young people to buy insurance because I need them to subsidize the older people. And I never hear politicians explain this. I always hear they say we got to get healthy people into the system to make the system more affordable. They never say we got to get young people in this system and materially overcharge them to keep the system affordable to the rest of the people. And they never say it like that. It's almost as if young people come in and that's the way it's supposed to be. Well, that's not how insurance works. Young, healthy people should pay less for health insurance. They're coming into the system, shouldn't help the system at all because they should be paying their actual rate. But the Affordable Care Act said, no, we're going to force young people to pay more than they should. Cross subsidies are hard to maintain when people can avoid being overcharged for insurance. So we're talking about the individual mandate coming out. President Trump got rid of it. So are young people buying insurance? Where if they're economically savvy, they shouldn't buy insurance if they're healthy because they're paying way too much for it. So here's the HIE did not find the people who cut back on medical treatments were less healthy than those who got everything the doctor ordered for free. In contrary, it found that even though people who were treated for free used more medical treatments, their health was effectively the same as people who had to pay. Again, another good quote on just showing the system is set up to spend money, not to make us healthy. And there's no relationship to spending the money and how healthy we are. Giving away health care for free, I'm on the almost to the end here, for free has enormous downsides. It encourages people to use treatments that are ineffective, harmful, and wasteful, and to rely on intensive medical treatments to cure what ails them instead of doing other things that would be cheaper and more efficacious, like exercising, dieting, sleeping more, cutting back. So we're getting treatments that don't help us in order to avoid doing the things that do help us, like exercise. So it's actually making us less healthy. To make medical treatments free also diverts enormous amounts of money for other public health priorities, back to that second article, that deliver more bang for the buck, like sanitation, housing, education, school lunches, pollution abatement. When hundreds of millions of people spend their own money on healthcare, they will behave differently, and healthcare providers will too. There's a great quote talking about the consumerism for healthcare. All right, so the last thing we're going to do for healthcare is I'm going to send you a link to a video. It's called Money in Medicine. It's several years old, but it's still, you're going to see a lot of stuff that's in these more recent articles. It's still true, has not been fixed. It may be slightly better today than it was in the past, and they'll talk a little bit in the video about some things even then that were getting better. That's the last thing we'll have. I'm thinking about having an outside speaker again. We'll see. I'll get y'all more information on that. But hopefully you're taking notes as you go, and you've got a great paper ready to go. So I might have made this same spiel at the end of the last class, but this is the last thing I'll be showing you in print. The only thing you have is the video. Thanks.